Resume my recording. Are you there?
Yeah.
Yep.
Okay.
Yes.
Okay, she's gonna make me talk to blank screens.
I just woke up, I'm not gonna lie.
No judgment. I just feel, in the world of Zoom, I think I've got PTSD from teaching through COVID. So, uh, all right. Well, there might be people that kind of cipher in over the next few minutes, but I just wanted to start like what are maybe some specific questions you have as you've been studying that I can maybe help clarify or um, explain a little bit better, struggling with? Nobody's got a question. It's all very clear.
I think I have a few. I like literally just woke up like a minute ago, so I need to get myself together.
That's
One
okay.
second.
If you want to start with like nasal fractures and what exactly meningeal tears are, that'd be cool.
Okay, so I mean, essentially, like when you think about, let me pull up my PowerPoint on that one. I'm just pulling up all my stuff. That way I've got it for you. So, like when we talk, wish I had a picture where you could kind of see. So when we would have like a meningeal tear, like we're getting back towards like where it could be um, spinal cord fluid. So like if we start seeing, and I don't know, I wonder if I've got like a picture I could probably find. But when we very rare complication, right? But anytime you do have that, if you've got enough trauma where maybe some of those bone fragments could have been pushed back far enough, right? You think like really, really intense, like head-on collision or something like that, where it could cause bone fragments to like push back that could cause like a spinal tear, then we would maybe be looking for some of that CSF fluid. And so then that would be, we would want to test, like if they've got nasal dripping coming and it's like clearish. Well, we've all had like sinus drainage, you know what I mean? That can be clear, like allergy drainage that is clear. But CSF is also going to have kind of that clearish appearance as well. So to test that, that would be where we could use like the one you can use like litmus paper or like there's like special paper, but even if you use like paper towel, it like gets a minor halo around it. Um, but like there is specific paper you can use to test it. Then you can also use I don't remember where I've got that. Um, like filter paper, or you can also use dipstick for glucose because it would have glucose in it. Does that make sense? So again, this is just like a super rare um complication. But it is something if you notice somebody had clear fluid drainage that they would watch for. Prime example of that was when I know I kind of gave you a little bit of my story about how I had that fracture. What I didn't tell you is I one time um I've had a lot of sinus complications. I was actually tested for CSF leakage because I had a huge polyp in my sinus. And it was so big that it was growing out of my sinus into my nasal cavity. I was a senior in high school. I know this is going to sound really silly and really dumb, but I was like, man, I just feel like I've got like something up in my nose, and if I can get it, I can breathe. And I stuck my finger up my nose and I burst that uh, cyst that was growing that was all fluid, and I just had fluid gush out of my head. It like filled my shoes. I was at home by myself and I called my mom at work. I'm like, hey, I just stuck my finger up my nose and something popped and now there's fluid everywhere. And giving my trauma with all of my other problems. She called the doctor. He had me come in and he made me sit there and like he watched me and they tested it. And he's like, if it does not stop dripping and I see another drip like in the next 5 minutes, we're going straight to surgery because he thought I had like a meningeal tear. I didn't. It was just a polyp that then they ended up having to do surgery and take out through my mouth, but whole different story.
Wow, that's kind of wild.
It was very wild.
You said it was
Sounds
a
Sounds
horrible.
polyp.
traumatizing.
It was a polyp on your sinus.
So it was down in like you got your frontal like these sinus cavities that sit right here. So it was actually uh like it's originated at the base of my sinus cavity, but it was so big and it filled the cavity and was like coming up into my nasal passage. It was like growing a finger, trying to find its way out, essentially. And so it was kind of coming down into my nasal passage. So he actually went up in my mouth through my jawbone into my sinus cavity that way and took it out through my mouth.
Ow.
Yikes.
Oh.
So when this happens, like if it does get that far, are you gonna have your normal like bloody nose, I guess, first, and then the blood's gonna stop, and then this is gonna happen, or is it you're
It
just gonna?
is right. Yeah, that's a good question. Like it is going to be really difficult in a situation like that. Like if there's like gushing blood, that's going to make it a whole lot more complicated if you thought you saw clear fluid, right? So, it would be probably after the bleeding has stopped if you notice clear drainage. Any other signs and symptoms though, where you could think just depending on the level of trauma too, they could test it. Connor, have you caffeinated enough to think of what your questions might be?
I've arisen, but I'm still dead.
Okay.
But if so for head and neck cancers, do we need to like identify I don't really know kind of what I'm asking. I guess I kind of do, but where like stuff is because I noticed that you point out like the regions that it can be in. Like, do we need
Mhm.
to emphasize like the different regions like the cancer can be in, or is there different complications that can occur depending on where
So
it is?
I think, I do think there is the ability to recognize how to differentiate what maybe some of those classic symptoms might be. Um, to be able to recognize like what type of cancer you're dealing with. And I break that down because when we say head and neck cancer, there's a lot of different
Yeah.
places it could be, so we can't just say it's a one size fits all symptom wise,
No, yeah.
right? So when we think about that, I'm not going to have the same manifestations for um, cancer on my tongue as I would if it's down in my larynx,
Mm-hmm.
right? So I do have to maybe be able to differentiate like what would be signs and symptoms that could help me distinguish like, oh, if I'm worried about um nasal like maybe cancer that's in the like sinus passage, then that might be nosebleeds, that might be frequent sinus infections, that might be headaches because it's all that sinus pressure from some type of cancer or tumor or something like that. Pain in the upper teeth, like anytime you've had a sinus infection, right? Have you ever had
Mm-hmm.
that before where it's like you physically, your teeth hurt?
Yes.
Yeah. So, like, things like that would be something that would be more sinus. Whereas if I've got a white patch or a red sore that doesn't heal in the gums, swelling, like, those would be things where I'm like, ooh, that's more oral
Mm-hmm.
versus sinus.
Okay. Okay, that makes a lot more sense. Um,
I have a question about like chest tubes.
Okay.
I feel like we've talked a lot about chest tubes. Should we
Uh-huh.
focus more on what to look for or like setup or
I think what did I put on your study guide? Complications maybe? Um, I can't remember what I even put on your study guide.
I
When
think
it
it was
comes to chest
complication.
tubes, yeah, so like when it comes to chest tubes, especially when we're talking adult health one, we didn't really go into necessarily, like with the critical care, we went into like pneumo, hemo, that kind of thing, which is more the disease processes that lead to the chest tubes. With adult health too, mainly we talked about like with lung cancer, they're going to come back with the chest tube. So we are looking for the maintenance and care and watching for complications with the chest tube. So we got to think about like our um, utilization of one. Um, how do we, make sure our connections are all connected, our dressings are secure. And then when we're looking at uh, our chest tube itself, where should we see titling? What happens if we don't see titling? Should we have continuous bubbling? Should we not have continuous bubbling? Where if, now if it's my suction chamber and it's a wet suction, continuous bubbling in the suction regulator is okay, but continuous bubbling in the water seal is not. So those are things that I would be looking for. Or, okay, if the chest tube becomes um, disconnected from the drainage device, what do I do?
put it
I
back
don't think we put it back in, do we?
No, no,
No.
on? Get a new one?
we do. But in the meantime, what can we do at the end of that
Do we
to
put it in
maintain our?
water, in
We
sterile
put it in
water?
that sterile water, right? We can put the end down in sterile water to maintain the water seal until I can get a new drainage device. If the chest tube gets pulled out from the patient, what do I do?
Do we put pressure for like,
No,
no?
Wasn't that where we had to like seal on three sides?
you got it. We're going to put a dressing over it and tape it on three sides to create that one-way valve. So again, when we get, you really like, when it comes to chest tubes, and I will tell you, like, I think NCLEX style questions over chest tubes is you really have to pay attention to the wordsmithing and what the question's asking you. Where is it a complication where it became loose? Where did it come loose? Did the chest tube come out? Because that is different than if the chest tube is still in place, but it got disconnected. They love to use the words bubbling, but where is the bubbling? Is it intermittent? Is it continuous? Where is it at? So, just making sure you really are paying attention to those questions in terms of what does it mean? And then there's also just your basics, like making sure your dressings are secured, making sure it's below the bed, maybe making sure there's no dependent loops, like things like that are also obviously important, that it doesn't get tipped over. Those are your basic maintenance.
What do we need to know about like okay, well I know we're not supposed to ask questions like that. I'm so sorry.
That's okay. What? Well,
That's just how I ask questions in general.
that's
I feel
okay.
like um so for like central lines and stuff, I get confused with like a midline and
Okay.
how that's not central. I know it's because it's like just like a slightly longer like catheter tip.
Mm-hmm.
Is that the only reason why it's not a central line? And it
Because it
doesn't
is,
go into the heart.
it's not going into central circulation,
Okay.
right? A central line is going to have a catheter that's coming out right at that superior vena cava, which
Okay.
is sending it instantly into like central circulation. A
Hmm.
midline is still only doing peripheral. It's a
Okay.
longer catheter, so there's less risk it's going to go bad.
Is that the point of it then?
Yes,
Okay.
they last longer, so they hold up better in the hospital, and that's why you see them, but it is not a central line. And that's why
Okay.
you'll also see like they'll go midline versus central line because if a central line's not indicated,
Mm-hmm.
but I just have really crappy veins, they might get a midline that's going to hold them over while they're in the hospital.
Okay.
Does that make sense? Because,
Yeah.
whenever I talk about CLAPSIs, um, I, if we put in a central line and we can't justify the reason,
We
then
don't want to risk them getting a
yeah,
C.
yeah.
Okay. Okay. And like those, oh shoot. For the TPN and all the fluids and stuff, we can't like the TPN, the total nutrition, we can't push that through a is that only peripheral or is that like depending on like the order? It can be put through like a G tube and stuff too, but
TPN is not
okay.
through a G tube. Now, that is going to be G tubes are going straight into your stomach. So, G
Okay.
tubes take in like your tube feeds.
Okay.
Okay.
Mhm.
Your TPN goes through a central line, and PPN can go in a peripheral line. So, they are different,
Okay.
right?
Hmm.
PPN is peripheral prenatal nutrition, which goes in like a large distal vein. It is short term. Okay. So, TPN is somebody that we're looking for, like they're going to have a PIC line, central line of some sort. And we'll see this a lot. Like if we see people getting TPN in the hospital, they usually have a PIC line,
Okay.
right? It's total has everything. So it's extended long-term use. They cannot eat at all. So say they are, I don't know.
No.
Um, so like PPN is somebody who's maybe been really sick for a long time, maybe had gut rest, but we're slowly introducing foods again, so they can take in some food. They're just not meeting all of their nutritional needs. So we can do PPN, but TPN is they are not getting really any uh, food at all, any nutrition, but maybe it's our short term because they need a G tube, but we haven't inserted one yet. Like we know this is long term.
Okay.
Um, so we might go that TPN route.
Okay. So like our PPN is like our like it's like our intermittent like deciding if we're gonna go long term or stay at the
Well, or it's somebody who had something acute, they were
Mhm.
sick, but they just need a little boost because if we don't help, they're going to get malnourished.
Okay. That helps a lot. Thank you.
Yep. And when we give, and I just want to kind of like reiterate on this, when we do TPN, what is what's something we need to really make sure? What are some of our best practices for that? What type of tubing do I use? Anybody know? Do I require a specific type of filter?
Yes.
To catch the
Yes.
particles.
Yeah. So if they are just getting the TPN, I can use like a 0.22 micron filter. But if they're getting lipids with it, which lipids run over 12 hours, but lipids is much thicker, then I'm going to have to do a 1.2 micron filter. But either way, either one of them requires a filter needle or a filter on the tubing. Some facilities might even make you do second nurse verification with TPN. Not all, but some. Okay. It is, I mean, fairly high risk with that just because You really run the risk of electrolyte imbalances. If you were to give the wrong TPN dosing to the wrong patient, that could be really detrimental to them. So we really have to be careful with that. Do you remember what I said if TPN is not available? So, like, say pharmacy got behind and they haven't sent up your next dose, your bag's almost empty, or your bag is empty and you don't have your next dose. What are you supposed to do?
Give D10W.
Yeah, I need to either give D10, D20 something. I need to actually give sugar because what happens if I don't?
They're gonna be hypoglycemic.
Right. So, and I don't know if you remember when we talked about this in class, like when you and I eat, our body does natural, I eat, my body increases my insulin production, right? Because of all the sugar that comes in to decrease my blood sugar, so try to keep it in normal range. So I have that body brings it in, liver, body, pancreas all go, okay, let me increase my production so I can keep your blood sugar at the same level. Well, when I'm doing TPN, I am constantly being given. It's like if I were to just sit and eat sugar all day long, and I kept that continuously going throughout my bloodstream, then my insulin production is going to be just at a baseline higher to meet the sugar needs that are going continuously in my body. So that's what's happening when I give TPN. I am continuously giving that sugar. So I am continuously increasing my insulin production to meet that intake. But if I instantly take away the intake, my body's going to still be creating that insulin level for a little bit before it doesn't just instantly stop. It takes a little bit for it to recognize. So I run that risk of with that insulin and no sugar bottoming out. Does that make sense?
Yes.
Okay.
Did you say these were like strictly application questions?
I mean, I would say for the most part, yeah. I don't have the test right in front of me. Yeah, I would say so. I'm not doing any like true or false. Um, it's not knowledge first level, first semester nursing school. You know it or you don't. It's definitely,
What?
I'm sorry. I gotta have you thinking. Let me see. Mm-hmm.
For the different types of pneumonia,
Mm-hmm.
um, I'm assuming you want us to know the differences and how they're acquired.
Mm-hmm.
Okay. And do you want us to know like if they're more resistant to antibiotics? That's kind of is that application sort of deal?
Well, yes. I mean, when it comes to that, I mean, you have your different types.
Mm-hmm.
Um, any of them run the risk of becoming antibiotic resistant if we don't do what?
If we don't like treat them.
That, and if we don't finish our antibiotics, right?
Yeah.
I mean, that's what's so important, and that's where we run the risk. Now, um, you do, there's probably a higher risk when you start talking about hospital acquired pneumonia versus
Mm-hmm.
community acquired because there's just honestly bigger bugs that live in the hospital because we can usually wipe out the smaller bacteria with good cleaning, but some of those bigger ones that are more resistant do get a little bit more difficult. So there is a risk with that, but
Mm-hmm.
it's more so just that recognizing how important it is that we do get antibiotics on board, why it's important that we do cultures of the sputum so
Okay.
we can make sure, like even with sepsis, we usually start with a broad spectrum, right? But then we get our cultures and those sensitivities and really then try to narrow down to the correct antibiotic for the bug that is present and the, uh, person. So that way we're not like creating um, super bugs, right? We
Hmm.
want to be more specific if we can. So that's why a sputum culture, if we can get it, is so helpful because we can really narrow down and get them on the correct antibiotic that they need.
Okay, that makes sense. And then PPD, like the not wait, that's not is that what I'm talking about? Like the tuberculosis skin test? Is that what that's called?
Uh-huh.
Yeah.
Yep.
Um,
Or Mantoux test. You can also hear it called Mantoux
oh,
test.
I haven't heard that yet.
Um,
Um, what is a positive like reaction? Like because I feel like everyone like reacts different and they read it different. Like
mhm.
when I've gotten it done, like I've had like a red dot, but then other times I haven't had it. It's I just don't understand it.
So, good question. And if you look at that slide, you'll notice where I've got skin testing. I've got Mantoux. It ends in X, so it's a weird word.
Mm.
Mantoux. So
Oh.
I do, and that's why I put PPD in parentheses, just because, especially again, you hear me say NCLEX a lot. They might say the Mantoux test on NCLEX, and you're like, what the heck is that?
Yeah.
Right? So it's recognizing it's interchangeable. It's the same thing with those PPDs. The big piece of that is you might have some redness, but
Hmm.
you're feeling for the induration.
Okay.
So
It's like
that's
a
why,
hard ball.
yes, that's what they're feeling for. So your induration is that actual swelling size that's measured, not the redness.
Okay.
Okay. And so, your book and like the picture I've got, your book says like 10 millimeters is where we go quote unquote considered positive. Whereas that image says like 15 millimeters is like general public with no known risk factors. But the 10 millimeters is like the, I don't know, maybe it's for us, everybody is a 10 millimeters because for us, we work in a hospital. We are the general public that we know,
Hmm.
and we are at a higher risk just based off of our profession. So I always just say, like, if you're at 10 millimeters, I would say that's where we start needing to do, I would consider it positive and do follow up with that. Now, if it's 5, but we need to know what risk factors they might have. Are they HIV positive? Have they been in contact with somebody who had active TB? Are they somebody who's had a transplant and they're on immunosuppressant drugs, so they're immunocompromised? Like these would all be things that if they tested even at 5 millimeters, we're going to start doing further testing to rule out TB because they're at a higher risk of contracting it.
Okay.
Does that make sense?
Yeah,
Okay.
I honestly have beef with that PPD test anyway because of nursing school. I just don't like it.
I'm sorry. Um, I can't remember. Is it the um I have beef with the blood test because my blood test one time came back. The whole blood testing thing is like to try to eliminate having to come back and get your PPD read. But then I had like a
Uh-huh.
false positive with my blood testing. They're like, oh, yeah, we get false positives a lot. So we needed you to come in and do the PPD. I'm like, could I have not just done the PPD to begin with?
It's
Because
so
now I
dumb.
got to come back and do the PPD and get it read again. So what should have
Yeah.
been 2 now is 3 visits. I
Hmm.
was annoyed.
Yeah, I had to do it like 4 times for school because you have to do it 2 times in a 2 week span, a week
Yeah,
apart.
I know. Sorry.
Yeah.
We all know it, and we all know it's the skin test, and we know it's the PPD, but I do make sure I like refer to it on there just so you've seen it, that word,
Hmm.
and it's not completely foreign to you. Because I have seen it on like a lot of NCLEX style questions where they call it the Mantoux test, and people are like, the who?
Yeah.
So, what else you got? If you don't have other questions, I mean, I can do a couple practice questions with you if you want to try a couple practice questions.
That would be awesome.
Let's do a few practice questions here. Can you see my whiteboard? So can you see the poll?
Yes.
Okay. Okay. I don't know who has an answer, but let's go ahead and look at it. Here's, we're going to play with this question a little bit. So you guys correctly answered C. That is the correct answer. Why'd you choose C?
They can't breathe. They're in respiratory distress.
My SpO2 is 88%, right?
Mhm.
That tells me they need oxygen. So when I
Yeah.
think about my airway breathing circulation, that is that's a breathing concern. I am low on O2. We're going to take the same question. I'm going to now change this to say, um, what are you going to do now? Would we change what we would do here?
I don't think so. I still think it's low.
Is it in, even if it's on low end of normal, is it normal?
It would be A or D in my mind, but I don't know if you would just administer the antibiotics right
What's
away or
what's our
wait for the blood
sepsis
culture.
bundle? What do we have to do first?
Oh, do the IV. Wait, now I'm confused.
When
Yeah.
we
It
when
says
we
antibiotics,
Get it?
isn't it?
I don't know.
do we have to get our blood cultures before we hang the antibiotics? We don't have blood culture results. We need to obtain the blood cultures because once
Mm,
I hang that antibiotic, that changes
right.
that does
Right.
interfere with my blood culture results. So I would obtain my blood cultures and then give my antibiotic. Yes,
Is this
Yes.
is this question like saying that this patient definitely has sepsis or we don't know yet?
it says they have sepsis,
Okay.
right? They have come into the ER. We are diagnosing them sepsis. So I don't, when you see that, we have to think about, okay, I look at those five. Now, let me do this. Let me change this to say BP over, what just happened? Sorry. I'm gonna do BP 70 over 35. Um,
The fluids.
yeah. I don't have a map score that's very good right now. And so, yes, I'm like sepsis bundle, obtain blood cultures, timeout, not priority at the moment because all of a sudden my cardiac circulation is not okay. Right?
Mhm.
So I think what's good about this question, I never once changed the answer choices. Do you see what I'm saying? All I
Mhm.
did was change the information you got in the question, and that changed what was the correct answer. So I think that that's, what I like about this question is it really helps us to recognize how important it is to realize what the question is asking you and not let your answer choices dictate the question, but your question dictate your answer choices. Does that make sense?
Yes.
Okay. Because if you read this and you just read the word sepsis and you said first, you're like sepsis bundle, obtain blood cultures. Got it. Hold up a second. You didn't really recognize what this question was asking you. You overlooked those vital signs that said, yeah, they're septic, but we're in real rough shape right now. This is where I go, you can fix infection, but you can't fix dead. And I got to fix this circulatory concern because my organs aren't being perfused before I worry about that infection. Okay, so here's another one you can do. New poll. Okay, you guys were between A and B. This is where we should suspect sepsis until ruled out. All right. They've now got increased breathing and acute confusion. Should I have an increased respiratory rate with a UTI?
No.
UTI is when it is contained and it is localized, I should not necessarily be seeing in changes in systemic vital signs, especially like breathing. So the thing is the findings are expected with aging is good because we go, oh, it's it, we gotta suspect that like an elderly might not have a fever, but they might not have a fever with sepsis. So we should, even though they don't have a fever, we are showing signs and symptoms that this could become systemic. I need to rule out sepsis. Does that make sense?
Yeah.
Okay. Let's see. What's a different one? This might be a good one. Let's do this. Mm. This is one where we get between B and C, right? Was that where you were? That's where I usually am, like with this type of question. And I think what's tough is because if we've got lung cancer, we're at a really high risk for frequent pneumonia, like frequent infections in our lung, just because of that impairment. So the correct answer is B, weight loss and hemoptysis. We don't usually have coughing up blood, and weight loss is really a major systemic side effect that is more characteristic of lung cancer than pneumonia. So somebody can get fever and chills because that body might respond to that lung cancer, especially if it's like a new nodule or something, and see that as like fighting off an infection. So if you saw that, we're doing chest x-rays, but it could be, um, if this is something new, body is responding like it's maybe an infection, but it's not. So weight loss and coughing up blood would be something that would be more lung cancer versus pneumonia. Mm, Here's a question. We'll do a few more. Um, okay. So if somebody comes in with suspected pulmonary tuberculosis, we initiate airborne precautions immediately. Okay. It's called TB rule out. And they're going to be in a negative pressure room until we have ruled out TB. Okay. Um, so this is one where would you wear a surgical mask if you thought they had suspected pulmonary tuberculosis? What type of mask are we wearing?
The N95.
Yeah. So I also say, like, and I know I talked about it in my voiceover, and I think this is something that really confuses everybody is, okay, this person comes in with suspected pulmonary tuberculosis. They need, they come in and we recognize a large nodule, uh, I don't know, large nodule, or let's say I don't know, large nodule, but they're going to actually need a lobectomy. I don't know. We're going to go down this rabbit hole, for the sake of this teaching purpose. They need surgery. Can they go to the OR?
I'm gonna say no.
This really throws everybody off. Say they come in and they need an MRI. We're going to say they can't have the MRI because we suspect TB?
No, they still go, I
They
think, right? And
do.
then
They
they
do.
give them a mask.
Correct. They wear a mask, but they can leave the room. They are not quarantined to never leave a negative pressure room again. And that's where we really struggle with this. Everybody's like, they can't go anywhere. They're stuck. They've got to be in negative pressure. Yes, ideally, we want them to stay in their negative pressure room to protect others. They might need treatment outside of their room. We cannot take everything to the bedside. So if they need to go somewhere, we can put a mask on them to protect others.
Do we put a like regular surgical mask on them?
Yeah, we just usually do a regular surgical to catch any particles or droplets would be caught in that surgical mask. So I think that's something that really confuses people with that. And so I always try to touch on that because I know that trips people up. Let's do this. We'll do a couple more. Good. So you guys all, so this is, what is this?
That plantar fasciitis.
Yeah. Having been a sufferer of this, I can tell you all too well, right? Oh, it hurts so bad when you wake up in the morning. Um, so do we instantly go to surgical correction? No, we are going to definitely try to correct this with supportive measures first. Good arch support, lots of stretching would be appropriate. If that is not helpful, we're not going to say strict bed rest, but we could see them get steroids. That would be kind of next step. And then if we still can't with stretching, supportive footwear, like a steroid injection, something like that. If all of that doesn't work, then we can start looking at surgical correction, but it's rare that we go the surgical correction route with plantar fasciitis unless we just absolutely have to. Okay, let's see. Here, oh, I like this one. Here, we'll do.
Is this question saying that rheumatoid arthritis is all of these compared to osteo?
It's saying if because you're going to have some similarities in some of your signs and symptoms. So which finding best would help distinguish maybe RA from OA.
Okay.
So you guys were between 2 and 4, and you're not. I like that that's where you are. A big difference with OA, and it's been a while since I recorded those lectures. I can't remember if I said it or not. With OA, like motion is lotion. I learned that from a other person that I taught this with, and she said that, and it made so much sense to me. If somebody's got OA, they've got really bad stiffness in the morning because they've been laying still, they haven't moved, everything just gets stiff, right? So they wake up, they've got a lot of pain initially, but once they start moving, it starts creating that synovial fluid and the pain will subside. Usually 30 minutes to an hour after they've got up and got moving, that stiffness will kind of go away. They'll feel better. So that morning stiffness lasting longer than an hour tells me that is more of a systemic inflammation issue versus a decrease in synovial fluid and stiffness with the joint. Because with like best distinguishes asymmetric joint involvement, you can definitely see asymmetric joint involvement with OA, especially if they were an athlete and they hurt their knee, back in the day. So their left knee might really have a lot more stiffness with OA, but you can also have some asymmetrical with RA2. It, I'm not saying it can't be a little bit more symmetric, but you can still have some asymmetry with it too. So best, that word best, I would say B is your correct answer there. Does
So
that
to
make
get it
sense?
straight though, both OA and RA are going to have morning stiffness, but the RA is just going to last longer than that hour.
Yeah, that RA is an actual autoimmune inflammatory response going on in there. So that pain isn't just going to go away. And I will like typically it hits bilaterally, but not to say you can't have RA that only hits one hand versus the other. It is typical to be bilateral, but if we say best, I would say B would trump D. Make sense?
Yeah.
Okay. Any other questions? I mean, we're close to an hour. We're at 9:55.
For like
Um,
the treatment like options, are we going to need to know like specific medications? And are there going to be like dosage calc on that we should be prepared for?
so And Davia, I mean, I think I put on your study guide like where that there would be dosage calc. And I think I think, granted, you need to know the medications, not just for my test, but for NCLEX. If if I have medications listed though under the study guide, then you need to know the medications that I talked about in the PowerPoints. So, like, let me ask this. Like, when we talk medication, acute gout. So, say they have a gouty attack. Do I do allopurinol or colchicine?
Is it colchicine?
Colchicine is for a gouty attack. Allopurinol is what they're on baseline. Like, if they've got gout, we put them on allopurinol to try to prevent attacks. Colchicine would be if they're having a gouty attack. I've got them on allopurinol. They've been taking it for years and they say, I don't think I need to take this anymore. I haven't had a gout attack in a long time.
Wrong.
Wrong. Yeah. You haven't had one because we've got you on allopurinol, right? That's what its job is to do, is to prevent you from having them. So it's doing its job. It doesn't mean you don't have gout anymore. It means the medication's doing its job to prevent you from having gouty attacks. That's kind of like saying, and you see it all the time with blood pressure medication. People are like, oh, I don't have hypertension. I don't need that medication. Well, yeah, you don't have hypertension because you take the medication. That's why your blood pressure is normal. That's why you need it. You stop taking it and magically your blood pressure goes up again. Any other questions? If you have questions over the weekend while you're studying, feel free, email me, and I'll be checking my emails. Okay. So happy to help, but um, hopefully this clarified a little bit. Really want you do practice questions. I mean, I can't stress that enough. Find an NCLEX review book. I like Saunders and Kleck's review books. Use the adaptive testing. I put that link on there for you guys. Like I didn't assign anything in your Elsevier practice questions that's on your website, but use the practice questions that your book gives you through that adaptive testing stuff. Like use practice questions, right? So the more you get in the thought process of how to kind of wordsmith some of these questions, the more confident you're going to feel when you get on those tests. Good?
Sounds good. Thank you for your review.
Thank
Oh, no
you.
problem.
Thank
Yeah.
you.
Good luck, guys.
Thank
I
you.
will see you Monday.
Thank you.